that haven't signed in, please remember to sign in. We're going to talk today about a problem that's increasing, as everybody knows, and that's the older trauma patient. Population is aging rapidly. The old dictums that once you're old, you're not going to do well have been shown not to be true. And so Dr. Samra, who you all know, and who's a product of this program, is going to talk about this, where we're going now, because this is something that's going to affect us all.
All right. Good afternoon, everybody. Thanks for coming. I'll get started. The topic is geriatric trauma. It's about our elderly population, and I have no disclosures, no industry issues. The objectives of my talk is I wanted to review the physiological changes that occur with aging, and I wanted to bring up some terminology points, some things with brevity, the occult hypoperfusion in the elderly trauma patient, some mechanisms they're unique to them, specific injuries they can have, and associate comorbid conditions which can go with aging. I would like to review the physiology and then the particular reasons for their injury, and then some specific management as well. So let's get started with the how old is old. We talk about in literature, if you see for the trauma, we consider more than 54, that's 55 and above is old for trauma patients. In medicine, I have read literature about 60 and even 65. And why this is important is you see by 2050, it projects that at least 86 million Americans will be over the age 65. That's almost 20%. And this is just exponential growth, which we're going to see every year over the next decades. Now, again, the same why it's important, because there's increase in the number of patients. I think on our surveys, on an average, I would say at least 30 to 40% of the patients are more than 54, that's 55 plus, keeping trauma census. So that's the importance of this. A lot of hospital burden and a lot of patients, you'll be seeing it more often. Now, why it is important to talk about them separately? Because I think they have a different physiology, a different reaction to medications, as well as to the disease process which they got injured with. So it's very important to know we treat them differently, not treat them as a young patient. So that's very important. The changes which occur with them, with the elderly population, is primarily because of diminished reserve, or if they have any concomitant disease factors, and that this limits their ability to absorb the physical insult and then also recover from it. So that's the key. I'll start with some systemic changes, like talk about cardiovascular system. I like to keep it more clinical, in which I would see that we often check the stroke volume on our patients, or we check the EF. It's important to know that with the age, their heart is stiff myocardium, so they have a heart which is less efficient. There's a decrease in the ejection fraction, and the stroke volume is decreased. Especially for residents, when we look at the stroke volume variation, that needs to be kept in mind. Going further, they could be on limited coronary blood flow because of the coronary artery disease. And also it's important to know that they could be on some medications. This is very important, especially in a trauma-based scenario when the patient is hypotensive, and you may not see the tachycardia response because they may be on a beta blocker. That's very important. And also with the diuretics to follow their urine output in the post-trauma setting in the ICU or on the floor. Talk about pulmonary changes. Their costal cartilage is more calcified. It's more, the compliance is decreased, the lung compliance, the chest wall is more rigid, and there's atrophy of the muscles. So that all leads to decreased FEV1, and we all talk about the importance of incentive spirometer in our trauma patients, or we talk about when they're on a vent, the incidence of pneumonia. So all these things are predisposing them to infectious complications. Further going into the VQ mismatch and alveolar arterial oxygen gradients, there is a decreased gas diffusing capacity. capability. There is a decreased airway sensitivity, decreased efficiency of the cilia to clear out the secretions. So that leads for increased risk of aspiration and pneumonia. Talk about renal changes. There's something which I want to highlight, very important when I came across. Actually, this was taught to me by one of the anesthesiology colleagues in my fellowship, that when we start chasing the urine output on an elderly patient, we always keep 1 cc per minute per year. But remember, the GFR drops after age 40. And I have seen a lot of scenarios in which elderly patient, we are trying to fluid overload them because we want to chase a particular urine output, and we end up putting them in pulmonary edema. So be mindful of that. And also they have a decreased response to the ADH hormone. So all these are physiological changes happening in the genitourinary tract. Further, there's a decreased creatinine clearance. There's age-related reduced muscle mass. So be cautious of contrast-induced nephropathy, and be hyper-vigilant in how you give them IV fluids, electrolytes, and the acid-base balance. We recently had a patient in the ICU. I think she is 70 plus with rib fractures and pulmonary contusion. I felt like in terms of fluid balance, we could have done a better job. She didn't go into AFib after she got admitted, and she's still on a vent, and we are having issues with dealing with her AFib and the pulmonary contusion. So just some few important points to keep in mind when you manage your patients in this particular age. Let's talk about CNS changes. It's further with age, there is a greater movement of the brain during impact because of there's a cortical atrophy, and that causes the more damage to the underlying parenchyma. And also why they're more predisposed to fall because of vision issues, auditory function, and the tactile sensation is decreased. And obviously the reflex time is also has to be kept in mind as well. Musculoskeletal changes, they have loss of muscle mass and strength, loss of motor neurons, and more adipocyte infiltration on these patients. There's erosion of the cartilage, and also it's important to know the osteoporotic changes which occur in their bones, which increase the risk of fracture. May it be ribs, or it could be vertebral collapse, or it could be pelvic fracture. Neurohormonal changes, in general, their response, the thermoregulatory response is impaired. The immune function is also impaired as the age increases. And these are all important because they have increased incidence of systemic inflammatory response syndrome because of the change in the neurohormonal status. The reserve as such, how they can tolerate the injury is also affected because of their cardiac index is lower, the maximal heart rate is reduced with advancing age. And this is the formula which is often quoted when the patient is, if not on any beta blocker, when we talk about how efficient the patient's cardiac reserve is. And so keep in mind that elderly trauma patient will have a lower cardiac index, lower oxygen delivery as well. And so they can suffer outcomes more worse as compared to young people from hypoperfusion. Now this is the top terminology which came across reviewing the literature on geriatric trauma, in which they talk about occult hypoperfusion. The rate of this particular entity was almost very high depending on the age population they were studying. It was almost 42% of the patients had normal vital signs. So that was the key which came across in the slides. Further, if you see that the lactic and the base deficit, which we use as the markers of oxygenation, we talk about whether there's any area of hyperperfusion in the body, we tend to trend the lactate in our clinical setting. So it correlates with the severity of the shock and the severity of injury. And in this particular study done in which there was almost 1,000 plus patients, the incidence of occult hypoperfusion was almost 20%. And after adjusting for the GCS, ISS, and advanced age, the venous lactate significantly predicted the mortality. And what we tend to follow clinically is we trend the lactic acid. After like hydration, it should tend to come down, though it's not an isolated factor, but that needs to be kept in mind for the elderly patient. And the OH, the occult hypoperfusion, was defined as lactic acid of 2.5 or greater. And in the further study over here, the 3 factors, they found out that the trauma service consultation early on, lactic acid measured, and the serial lactic acid, which we trend. Now, you must have heard in our checkouts, different attendings debating about the lactic acid, but I think the key message is you need to trend it. If it was high initially, it may mean nothing, it may mean something concerning, but you need to trend it. If it's coming down, that's reassuring. So keep that in mind. Now, how to triage the geriatric patient? Accidents will occur, and the system stays the same. There has to be the same activations for tier 1 in terms of the hard signs. But be mindful that there is an issue of degree of injury could be underestimated. And age more than 65 is independent risk factor under triage. So it's better if the patient has an elderly patient, and when in doubt, they need to be transferred to a higher level of care, especially in a trauma center. And don't be fooled by the normal vital signs. If there is altered mental status or there are concerns about any comorbid conditions, they should be triaged to a level 1 trauma center. Though age alone should be a criterion for trauma triage activation, should be also kept in mind. Sometimes we see there's a elderly patient, we get calls through a learned system, and that's always a risk factor that they need to be seen at a higher level of care. Though we have all these discussions we're talking about, we have our East Society, the Eastern Association for Surgery for Trauma practice guideline. We don't have really, in terms of evidence-based level 1 data for this, which basically means randomized controlled trials for that. Level 2, when we say it's case control studies, and level 3 is basically expert opinion. So, but anyways, clinically one should have a lower threshold for activation for a geriatric trauma patient at a trauma center. And if you have obviously GCS less than 8, no improvement in the 72 hours, one should consider that in order to have less comorbid conditions down the road, complications, better to be seen at a level 1 trauma center. So that's the key. There's just an algorithm to show that if I'm over here, the age is being used as 65 or more, and if there are pre-existing conditions and you are suspecting that, it's beneficial to go to the trauma center, level 1 trauma center, and also it's important to measure the coagulation parameters. And it's very important because of the age-related changes in the CNS we talked about earlier. Because of the cortical atrophy, a head CT is important to be done, and if the GCS is 15 or there's a base deficit in terms of occult hypoperfusion or any particular anatomic injury present, is important that it should go for the full TREAM activation and ICU care. And if the patient does well, then you can further triage your care later on. Now let's talk about some mechanisms of injury in an elderly patient. We see a lot of falls. These days you see a lot of patients coming with falls. Almost each time you're on call, you'll get 2 or 3 patients with fall. MVCs, if they have more functional status, they are driving. We see a lot of pedestrian versus car because of their slow gait or decreased reflexes, burns, assault, and be mindful of elder abuse as well, which is, I would say, underreported, and then some other self-harm as well. Now, the falls are the most common, and at least 28 to 45% of elderly people in the community in a year. A lot of nursing home patients we see on our service, and it's second only to motor vehicle collisions in those from 65 to 74. So it's more changes occur in women because of the osteoporosis and decreased muscle mass. For risk factors, they may not be able to use their assist devices properly. They may be diabetic, have peripheral neuropathies, alteration in their gait, decline in their proprioception, vestibular coordination. So all these are risk factors, and the most important, which I feel which we could do a better job is polypharmacy. We put them on a lot of medications, and sometimes the telemedicine works that my so-and-so symptoms are not getting better, and the physician tends to increase the dose without seeing the patient. I've seen a lot of issues with that, and be mindful that some of these medications have their side effects as well, like hypotension or sedation, which could lead to their fall or even motor vehicle crashes. Trying to talk about some fall prevention strategies, we need to have a change in the environment. For example, where they live and the lighting status, repair of loose carpets, and have some more placement of grip bars. Also, the polypharmacy needs to be addressed, and use of mobility aids. That's what, once a trauma patient comes with a fall, there was a role of injury prevention can come into play. We have to be proactive in knowing what was the reason for the fall was. That's why it needs a good workup, and then only we can fix what the reason was for the fall. Talking about the motor vehicle crashes, the elderly, and more than 75 age has the highest incidence of traffic fatalities per mile driven. So this is despite driving less frequently over shorter distances, and there's age-related impairment of the driving skills because of decreased visual acuity and delayed reaction time. So these are the reasons. Be more likely to crash, just environmental factors, good weather, or on a weekday, during daytime, in a location usually close to their home, and usually it involves another vehicle. And absence of other causative factors like speeding and ETOH, which usually we see in a younger patient population, though exceptions are there as well. We do see on a service once in a while. And then talking about the pedestrian injuries, because of decreased peripheral vision, hearing, audiovisual component, that's important, and speed needed to cross a crosswalk is about 4 feet a second. So 1/3 of the pedestrian fatalities in those older than 65 years old occurred in a crosswalk. So that's an important thing I came across. More likely to suffer injuries, especially to the head and chest, because of the mechanism how they fall down. Be mindful of the burns in the elderly, account for about 8% of trauma deaths in the elderly patients. They have a decreased cutaneous sensation and diminished reaction times, and that prolonged thermal exposure can lead to more extensive and severe burns. And exceeding almost half of the body surface area have higher mortality rates, and because of the decreased pulmonary reserve, if there is any inhalational injury, that would lead to further consequences of, say, pneumonia, aspiration, that can cause issues with the respiratory status. One has to limit the burn for resuscitation because of the limited cardiovascular reserve. So it may not be a bad idea on these patients to insert a flow track and monitor their SVV as an objective marker. Be mindful of the violent crimes against the elderly. Decreased mobility and strength make these populations unable to defend themselves. So be careful of that as well in terms of when you are getting the mechanism of injury, be suspicious. I think we do a very good job with kids. We always pick up the CPS, but be mindful that even elderly abuse is common and is underreported. So that needs to be kept in mind. Abuse and neglect, on the same lines with the females are more abused than males. Those older than 80 are abused 2 to 3 times more than those 65 to 80. There's a further fractionation here in terms of age. So again, high degree of suspicion, especially when signs of injury or neglect are inconsistent with the story, the same principle which we follow for our pediatric child abuse. Suicide in the elderly, depression is a common cause, and then they may have a chronic illness or chronic pain, or they have any oncologic problem which is incurable. And myself have seen a bunch of suicides happening on a weekend. Patients coming with this, so be mindful of that. And I would like to talk something specific about some specific injuries. So let's talk about some spleen. These days we do have the non-operative management of splenic trauma, but be mindful that in this particular patient population, the weakened capsule and the vasculature is very fragile, so that could lead to a decrease of smooth muscle elastin fibers. And they do not contract and retract as well as compared to the younger population. That's why you must have noticed that patient age cutoff is 50 or 55. They have tendency to fail the non-operative management of splenic trauma. So keep that in mind always when you're putting the patient through that algorithm. Though also be mindful that the hypertensive episode, they may be poorly tolerated by a patient. So I put in the end a splenectomy, the conservative treatment, because you're doing it early, heads up, so you don't have the unintended consequences of putting the patient through the non-operative management. The blunt chest trauma, here commonly seen, we see our patients, they have a fall, and then on top of that, there is the pain control is an issue, they aspirate, there's a risk for pneumonias and ARDS. This is a very common scenario which we see, and the more the number of ribs you see fractured, the higher the incidence of infectious process these patients can have. And the mortality increases in the linear fashion, the rib fractures. Very commonly seen problem. Actually, right now, we have one patient in the ICU as well. And I think as a team, we are trying to come out with some algorithm in how to treat a rib fracture more proactively and early, because the challenge we face is the fluid balance versus contusions flaring up versus aspiration and pneumonia. So it's a combination of things. We have a young patient who had an inhalation injury, came on the 31st, and now is on ECMO. So be mindful of what all we are dealing with because of the comorbid conditions and the underlying reserve, which they don't have much. This is just a chart to show that as the number of rib fractures increase, the mortality increases exponentially. Pain control is the key. We talk about the fifth vital sign. We have to strike a balance here though these days, but we also be careful that we avoid over sedation with IV narcotics because of the issue of hypercarbia and hypoxia. So epidural analgesia, if indicated early on, should be kept in mind. On-cue pumps, intercostal blocks, and lidoderm patches for the pain control. Talking about another important topic in this particular patient population, traumatic brain injury. Age more than 65, if you adjust match the GCS and the intracranial pathology, they have a higher mortality, age more than 65, and the linear relationship between the age and the mortality. So keep that in mind because cerebral atrophy and increased intracranial space. Though these days we're also talking about the management of TBI by acute care / trauma surgeons and not neurosurgeons. For that, the indications are very specific, say 4 millimeter or less than the bleed with no shift, no blood thinners, no confounding factors for the examination, say dementia or Parkinson's disease. So that also has to be kept in mind. Be mindful of that because of their anatomical changes with age, the subdural hematoma will be larger and have a more midline shift and higher mortality as compared to the younger patient population. So that's important. But epidural is less because the dura usually adheres to the skull. On the same lines, one has to be mindful of early aggressive imaging on these patients if there is the clinical concerns, and one should be careful in the exam, and it should be documented clearly what component of GCS you are evaluating. There should not be, I see a lot of subjective variation sometimes in the verbal response or in the eye response. The motor is the most important. As we all know, it's easy to examine as well. Very important topic. This is the challenge we face these days. Almost everybody is on some form of blood thinners. We are facing with Coumadin, Plavix, aspirin a little bit we all aware of, and the new ones, Pradaxa, Xarelto, Eliquis. We see that these patients are commonly coming in our trauma bay, and the mortality rate is very high on these patients because they are on anticoagulation, because that increases the chance of they bleed because of the fall. So the key is the rapid reversal of the anticoagulation, and for particular, we have this K-Centra these days, which should be used for Coumadin, for Plavix, ASA. We can use platelet transfusions or DD AVP, and then for Pradaxa, we have this new Prexban antibody. For Xarelto and Eliquis, basically there is nothing but PCC can be tried. And I think the more as we go further, people are following the ROTEM or the TEG we are trying to use in order to be more specific to see what particular factor they're deficient in and how that can be reversed. East guidelines on this, how should coagulation based coagulopathy be treated? Again, insufficient class 1, class 2 data to support any standards regarding any of the questions posed by this question. It does talk about we should have an early coagulation profile on this patient and should have an early head CT and should have a correction of the coagulopathy early within a couple of hours of admission. Again, guidelines, no protocol, a challenge because we don't have any level 1 data for this particular problem. Spinal cord injury, the pre-existing medical conditions and deficits may confound the exam. The patient could be diabetic, could have scoliosis, could have the degenerative changes, so that those could be confounding factors. And odontoid fractures are most common. We obviously see in all our patients, most of our patients who get admitted. That needs to be kept in mind. Particular attention should be paid to central cord syndrome. It's an age-related spinal stenosis and osteophyte formation which occurs, causes increased risk of this particular entity. And I think this particular clinical picture and also these slides are important for residents for the written exam as well. You will see this a lot, why you have a particular pattern of upper extremity more than lower extremity in a patient with central cord syndrome. And the bleeding is more seen in the central regions of the cord. And that's important. Acute hyperextension with pinching of the spinal cord occurs, and that causes this particular entity. Sometimes we need an MRI to diagnose this because CT may not be able to detect the bleeding or the ischemic area. And be mindful, you may not have a concomitant bone injury with this. And studies have shown that bladder control and ambulation only restored 20 to 40% of the time in this particular syndrome of the spinal cord injury. And mortality is almost more than 50%. Outcomes, both short and long-term outcomes are worse in geriatric trauma patients because of more pre-existing medical conditions and reduced physiological reserve. They also tolerate hemodynamic instability poorly and because of the increased rate of cardiac, respiratory, renal, and infectious complications. More aggressive management required or not. We are a lot of in the ICU care, though it could be, it's a little bit not very clear, but if you are worried about their fluid balance, I think it may not be a bad idea to consider flow track or SVV. And with these days we have those tools rather than going more aggressive with the PA catheters. But some people are even aggressive in using that as well in some of the ICUs. In terms of, again, East guidelines, is in the question raised is indiscriminate invasive cardiovascular monitoring with PA catheter and supranormal resuscitation still justified after injury in older patients? Again, we don't have level 1, level 2 in terms of data to support this, but we are aware that they should be treated in designated trauma centers, preferably in the ICU staffed by surgical intensivists. The outcomes will be better. We briefly mentioned earlier about the occult hypoperfusion. The base deficit should be, again, serially checked and then the outcome assessed accordingly. In terms of talking about the discharge, significant number of elderly patients who survive their acute injury are able to return to levels of reasonable function and resume independent living. This was a report from Pennsylvania about talking about a big cohort of patients. Almost 52% patients went home directly, 25 to the skilled nursing facility and 20 to the rehab. And it's a multidisciplinary process. Home health agencies, the family support, and spouses, they all play a very integral role in this. Though it was also mentioned by a study done by Gerber et al. In 1997 that increased risk of death in elderly trauma patients persists for 5 years after their hospitalization for injury. Just recurrence risk factors they're not looked into. I think that was the cause in this particular study. Conclusions, if I have to kind of summarize, it's a broad topic, but I do want to emphasize the importance of There are anatomical changes, the physiological reserve, one should keep that in mind. The triage system, it's preferable to be seen in level 1 trauma center. Be mindful of their blood thinners if they're on, and the goal ultimately is to recognize and not under triage them. Though we are trying at some centers, we are trying to have geriatric trauma service in which there is a geriatric medicine trained physician / hospitalist who is rounding with the trauma team and helping with the tuning of the medications and especially the polypharmacy part. But here we do round with our pharmacy colleagues, and they do help us with paying attention to those medications. So it's a multidisciplinary process, and I would say down the road, powers to be, Dr. Owings is here, we can ask him and see how the direction is this place going to go in terms of geriatric trauma service and go from there. But this is all I have, and if you have any questions, feel free to ask me. Thank you. We do have I think, in the internal medicine department, a geriatric person, I think. Right, Ms. B, is that correct?
So we had an experience not too long ago about somebody trying to report elder abuse. And unfortunately, it's not quite the same as CPS. The person actually has to go home before they can do anything, which didn't make a great deal of sense to me. And ultimately, the patient felt safe going home, but it's like if you have someone that you're really afraid is being abused, and that's a serious problem, sending them back to that environment probably is not the wisest thing to do. But that's currently the policy for the state. It didn't make much sense to me.
Holly, do you see, Holly, this in terms of injury prevention for the elderly patients? Do you come across some dynamics with the family members?
About elder abuse?
Yeah.
No.
Yeah, it's
Not a lot.
It's not something that we actually have seen very often, or that we really had concerns for. And maybe that's because we're just not as good at recognizing it as we are for child abuse. I know it happens. It's just that it seems to be we recognize it less often than we do for children, which we need to work better for that.
It's easier to mask. I do think that in the coming, as they accelerate the changes to what is the current orange book or blue book or green book or whatever color it turns out to be is now irrelevant because every 2 to 3 months they come out with additional criteria. I do think that a geriatrician is going to be one that will be required by the time we get up for our next level 1 verification. One point of clarification I think that is worthwhile is that the heart rate formula, which is fairly well established in physiology, that is 220 minus the age, is the maximum heart rate. And that's actually not a number that you necessarily care very much about, because what the maximum number of beats per minute a person's heart can achieve is less relevant than the maximum number of beats the person's heart can maintain. And so the maximum aerobic heart rate is the 220 minus the age, and then you multiply by a fitness factor. And if you're an Olympic athlete, the fitness factor is 75%. If you're sort of average person walking around, it's about 66%. So that gives you a better sense of what you can maintain in the ICU. So if you're looking at somebody with a heart rate that is 200 and they're 20 years old, that's their maximum heart rate. That's not their maximum aerobic heart rate. And so you've got to calculate, you got to add the fitness factor into it. And the fitness factor, which is to a degree, it's a fudge factor, but is well established in physiology literature, and you can pretty well eyeball somebody and get where that is. So I also think that the Swan-Ganz catheter is something that has gone away, but maybe actually starting to come back as we get elderly patients more and more, and because most myocardial infarctions occur on the left side, and a central venous catheter really only gives right heart pressures, a good assessment of what left atrial pressures are, I think, is important. And the reason being is that occult myocardial infarctions associated with the injury are one of the leading causes of mortality in the geriatric population.
I think they are talking more about putting the PA catheters in patients who have underlying structural heart disease as well. I've seen that in some of the ICUs, they're doing it proactively at the onset of admission to the ICU.
And it helps you with your resuscitation. So if you have a PA catheter, again, the absolute numbers for the wedge are probably less relevant than being able to, and it's really the gold standard for measuring cardiac output. FlowTrack is pretty good, but it's nowhere near as accurate as the PA catheter. And so the PA catheter, if what you do causes an increase in their cardiac output, and probably that's a good thing, unless it's simply by adding, meaning if it's fluid or if it's diuresis, managing their volume status. If it's by adding if you're cheating and you're adding a cardiotonic agent, then that doesn't count. But other things, I think that's something that as the population ages is going to come back in rather than